Hello, everyone, and welcome to today's International Pediatric Association webinar entitled Variations in Prenatal Screening of Congenital Heart Defects Worldwide. I thank you for joining us. I'd first like to thank the IPA's authorities, Dr. Joseph Haddad, who will address us in a few minutes, Dr. Naveen Thakur, and also Dr. Mehmet Vural, who is the chair of the maternal health subgroup, and the members of the subgroup who have supported and made possible this session. Thanks to them, and thanks to our distinguished speakers who will be joining us today from Saudi Arabia, Rima Badr, from India, Dr. Balu Vaidyanathan, and from the United States, Dr. Emilio Quesada. During the session, if you have questions for the speaker, kindly write them in the Q&A chat box. You will receive, and we will go answering them during the webinar, and some of the questions will be answered at the end of the webinar. To receive the certificate of attendance, participants must attend the entire duration of the webinar and complete the feedback form. The feedback form will be available once the webinar ends through the Give Feedback option that appears upon closing the session. Please note that the Zoom closed captions are generated by AI, and there may be instances where the translations may be incorrect or misleading, so take that into account. I'll introduce the president of the IPA. Dr. Joseph Haddad is a professor of neonatology and the president of the International Pediatric Association. He's a distinguished pediatric leader dedicated to improving neonatal and child health globally through advocacy, education, and international collaboration.
Thank you very much. Am I audible? Yes, I think I'm audible.
Yes.
So good day to everyone. And my first wish is peace. I hope that peace will be achieved very soon in our area. As you might know, we are in a turmoil area where children are suffering. And in that context, I really appreciate your input actually in improving the continuing medical education webinars of the IPA, even though we are really in a very critical situation. I wish to thank Sophia and all the distinguished speakers on this very important topic. Moreover, I wish to thank the group by itself, led by Mehmet Mural, and I wish you all a successful webinar. Thank you again for your keen participation, and I leave the floor for you now, Sophia.
Thank you very much, Dr. Haddad. Well, my name is Sofia Irinenko. I'm a pediatrician and a pediatric and fetal cardiologist based in Argentina. I'm the head of the fetal cardiology section and consultant pediatric cardiologist at Hospital Italiano de Buenos Aires. I am also director of the fetal cardiology fellowship at Hospital Italiano de Buenos Aires. I am a member of the maternal health subgroup of the International Pediatric Association, also participating in the Argentine Society of Pediatrics, the Fetal Heart Society, and the Argentine Society of Prenatal Diagnosis and Treatment. Today's topic leads us to a very important subject. Prenatal diagnosis of congenital heart defects allows improving the survival and decreasing the morbidity of patients with congenital heart defects that are the most common anomalies at birth worldwide. But prenatal detection varies widely across different regions, and this depends on resources, on healthcare systems, and also depends on cultural and religious beliefs. So today, we will address these subjects from a global perspective. We will focus on the limitations of and pitfalls of screening in high-resource settings. We will look at the challenges of screening in a very large scale populations, and also we will get to know a little bit about the impacts of religious and cultural factors on prenatal detection. I will introduce our first speaker, who is Dr. Emilio Quesada. Emilio Quesada is a pediatric cardiologist at the University of California, San Francisco. He's specializing in fetal cardiology and the prenatal detection of congenital heart disease. He serves as Director of Quality Assurance in the Fetal Cardiovascular Program and as Associate Program Director of the Pediatric Cardiology Fellowship at UCSF. His research interests include fetal cardiology, genetic arthropathies, and global health. Thank you, Dr. Emilio Quesada, for joining us.
Thank you, Dr. Vianenko, and thank you to the International Pediatric Association for the invitation. I will share my screen and start my PowerPoint. I just want to make sure you guys can see the first screen with our slides. Okay, thank you. So, as mentioned, my name is Emilio Quesada. I'm a fetal and pediatric cardiologist at UCSF in San Francisco. And today I will be discussing pitfalls and limitations of prenatal screening for congenital heart disease in high resource settings. So I represent one state, but in essence, a country with high resources. So I want to first state my case and just show you why am I going to show data of one state and not the whole United States. I will be presenting data from all the United States, but I just want to highlight that California as a state has a very large geographical area of about 424,000 kilometers squared with almost 40 million people, right? So this compares to medium-sized countries such as Poland and Morocco, Marruecos, were the two countries that were closest to the state of California. For example, our northern neighbor, Canada, has 15 million people and a much larger mass. Spain and Iraq are close in both size and population to California. So hopefully the data that I will present will represent a medium-sized country and give you an idea of the aspects of prenatal screening. I first would like to start with somewhat of a long case or a slide that's relatively full. I'll present a false positive one to show costs, and then I will stay focused on a false negative case for the rest of the presentation. So this is a routine 20-week ultrasound on a patient that had an uncomplicated pregnancy at the beginning. The initial anatomy ultrasound suggests multiple anomalies, including the kidney and the brain, and a suspected possible surgical type of congenital heart disease. The family is told that the baby may need surgery. They do a local fetal echo outside of the city limits in where I live, and the fetal echo is actually suspicious for something called an aortopulmonary window. A window is something very difficult to diagnose on fetal echo, but the family is told that the patient may need surgery with uncertainty, but the patient is urgently referred to the city for confirmation via a fetal echocardiogram in San Francisco. The rest of the pregnancy during the latter stages of pregnancy in the second and third trimester include multiple weeks of uncertainty, multiple repeated ultrasounds, and at least 2 fetal echocardiograms trying to rule this the congenital heart lesion. Given that there were multiple anomalies and a suspected congenital heart disease, the decision was made to recommend that the patient be delivered in a tertiary care center in the city. So the mother is referred to Benioff Children's Hospital in San Francisco. And at the end of our story, the postnatal echo after the baby is born is completely normal. There is no aortopulmonary window and there is no cardiac problem. So I want to show you, this is a short research that I did to see the costs in the United States associated to this type of case, right? We see that fetal echoes alone can be somewhere in between the $2,000 to $3,000 cost, and this patient received multiple echoes. The family had to relocate from 2 hours away from the city to the city. They consulted with multiple specialists, including maternal fetal medicine specialists, and required multiple follow-up appointments with them, leading to significant cost. The estimated impact was somewhere around 20 to 50,000 US dollars, which is to me quite incredible when you have it in a worldwide perspective, right? This is on top of parental stress, missed days of work, missed family days, etc., right? This is a significant emotional burden of weeks of fear and uncertainty for the parents. And at the end, a diagnosis that wasn't even there. So quite concerning. I'm going to move on to the next case, which is a false negative case. This is much, much simpler. It's a term healthy pregnancy, normal level 2 anatomy scan that presents at 3 days of life with shock. The baby is diagnosed via echo with coarctation of the aorta, and the patient fortunately is started on prostaglandin and stabilized, right? Based on the echocardiographic findings, the baby is diagnosed with critical aortic coarctation. Both of those cases illustrate a false positive pregnancy with its costs and a false negative pregnancy with a significant impact of congenital heart disease. So what we're dealing here with is a paradox, right? Our paradox is that despite more advanced imaging and increased standardization scans, we're still not detecting everything as the way we think we should. So what is screening? Screening is not diagnosis. Basically, it's about identifying who needs a closer look after the initial screen. And you can see here in the first diagram that typically what screening entails is a sweep on the baby from the viscera all the way to the mediastinal anatomical structures, trying to identify red flags to then proceed to a more formal diagnosis, right? At a minimum, we are talking about a 4-chamber view and outflow tracts. In this image, you see the 4-chamber view in the bottom section, and you see that with sweeps and with changing the angle of your probe, you can go from a 4-chamber view to the outflow tract views. Here's the left ventricular outflow tract, right ventricular outflow tract, and the 3-vessel view. The issue here is limited detection. First, I present a wonderful diagram done. This is published now almost greater than a decade ago. And depending on where you are in the United States, detection rates 10 years ago used to range in between 20% in some regions, like in the South, to 46% in the Northeast, where there's a large accumulation of cardiac centers. If you note all around the states, it's around 30%. So this is not a technological problem, it's more of a systems problem. This is a simple graph that I created in showing you in the setting of high resources, what is the difference between reach of a screening system versus detection with a screening system. As you can see, in the United States, there's near universal exposure to screening. About 99% of pregnancies are estimated to have at least one prenatal ultrasound, which is excellent, right? But reach does not equal effectiveness. If you note on the right side of the screen, you see that the detection rates in contemporary data that I will show you in later slides range somewhere in between 43 and 56%. There's a large California study done by our colleagues in Kaiser that show a capture of about 62%. I will show this data in the upcoming slide. So this slide shows this very important article published by a colleague and dear friend, Dr. Sanjay Vepa. He published the data of a hospital system called Kaiser Permanente in California. What they did is they did an analysis of nearly 250,000 pregnancies, live births. Of those, there were significant congenital heart lesions detected in approximately 300 patients. What they detected was that 183 patients were able to be detected prenatally for an approximate of 62% detection rate. This paper is very, very important because it highlighted something that I've always thought about, and they found that screening modality is very important. Kaiser has a very organized system and is very cost effective, and they compared prenatal ultrasounds performed by maternal fetal medicine specialists and compared it to those ultrasounds performed by radiologists. The difference between those two groups is training, right? Maternal fetal medicine specialists typically will get training in fetal cardiology and fetal imaging. They noted that by the screener, the difference is significant. 75% was caught by MFMs and a little bit less by radiologists. Despite that, we see that radiologists have a good percentage of capture, right? So this paper is wonderful because they estimated something called the number needed to detect. And they mentioned that at least 7 fetal echocardiograms need to be performed for each case of significant congenital heart disease. And this just suggests that effective detection without high volume fetal echocardiogram can be achieved. Again, this is from a very unique institution called Kaiser Permanente. I also want to highlight that the detection of congenital heart disease varies dramatically by lesion. If you note on this graph, on your left side, you see hypoplastic left heart syndrome and other single ventricular lesions. If you see the detection rate here is quite high, right? We're talking higher than 70% detection rate. And this is because those single ventricular lesions tend to be easily visualized on a prenatal ultrasound. The 4-chamber view, which everybody feels relatively comfortable interpreting, is very abnormal in those. But then if you know in common lesions such as coarctation of the aorta or even transposition, which typically will have a normal 4-chamber view, but an abnormal outflow tract and 3-vessel view, typically the capture there goes way down to less than 30%. So the lowest typically being coarctation of the aorta and total anomalous pulmonary venous return, which is always a challenge. So as I mentioned, detection varies approximately 40 to 62% higher in MFMs, and when compared to general imagers like radiologists, the prenatal diagnosis improves stability at birth, and I will try to show you that. And missed congenital heart disease would lead to clinical decompensation in neonates and delayed intervention. So it's an important thing. Screening is a thing that is high reach in population-based activities, but only moderately effective. So then I'd like to conclude our clinical case, and you will see that the prenatal echo on a patient with coarctation of the aorta sometimes can be very deceiving. You may have subtle features like RV to LV size discrepancy and sometimes just subtle arch asymmetry, making the ultrasound look normal and having missed this diagnosis, right? Most of the time, what happens is those diagnoses are made postnatally. On the right side of your screen here, you see how the arch is in a coarctation of the aorta. So this arch looks very abnormal when compared to this one, but the findings are subtle. If you are not accustomed of seeing those images, this image on your right might appear normal to you and it might pass you, right? So the question is what happens with those missed pregnancies? We mentioned that most of them will undergo a prenatal ultrasound and about 60, let's say 60% are detected prenatally. So we have a 40 to 50% patients that are diagnosed postnatally. They are largely not on-screen patients. They are all screened with ultrasound. And what they represent is a screened patient, but not detected cases. So if you think about it, those are false negatives. So how do we reframe this problem? We got to know that we don't measure screened or missed directly. Postnatal diagnosis are a practical proxy. That means, like I'm going to say this, try to say it twice, but every postnatal diagnosis in a low-risk pregnancy is, in effect, a negative prenatal screen. So it's important to understand that. The prenatal screening is high reach, but imperfect in detection, and implications mean that we need a layered detection systems. There are important physiologic aspects of why things are missed in prenatal screening, starting with prenatal circulation, right? Fetal circulation is something that's very difficult to understand, and most of us don't get training on this in general pediatrics. It is important to understand on a diagram on your left that in the fetus, we have what's called as parallel circulation. We have a ductus arteriosus, which is a blood vessel that decompresses or allows the right ventricle to pump blood to the systemic circulation. And this sometimes will bypass obstructions on the left side and even the right side. So the ductus helps the fetus survive. And the pulmonary vascular system is receiving only little amounts of blood flow, which makes us miss significant things such as total anomalous pulmonary venous return. On the postnatal circulation, this one is different because it works in series. The ductus closes and we lose the bypass in fetal life. And therefore, after birth and ductal closure, those lesions become hemodynamically evident. So with this graph and this very important paper published recently in 2023, we see that detection is improving over time. What this graph shows is all the different regions in the United States, and we see that from the early 2000s to the current era, let's say in the past 15 years, there has been an improving rate of detection. We are now seeing rates approaching 60 to 70% in many areas. But even with that progress, a substantial number of cases are still missed, and we find them postnatally. This is another important paper. This is from outside of the United States, from the Czech Republic, that showed the effects of introduction of a prenatal screening system. I'm going to try to summarize this because I'm running out of time, but the clinical incidence showed no significant change, but the detection was significantly increased. First trimester screening showed early diagnosis, and in countries such as the Czech Republic, there was a significant increase in termination of pregnancy, more so if bad diagnoses were made early. And following that, the postnatal congenital heart disease decreased as you would expect, right? Early detection would shift outcomes with fewer liveborns with heart disease. In the same paper, we see that lesions are very important. On your right, we see that hypoplastic left heart syndrome, here having mitral atresia and other forms of hypoplastic left heart, are obvious because they are seen in the four-chamber view. Congenital heart defects that are low detection rates are the ones that I mentioned, coarctation and TAPVR. If you see here, we're still in the 60%. So why do we miss them? There are systemic factors, biological factors, and cognitive factors. I'm not going to spend much time in reading this, but I want to highlight that this is a systems problem, not just an imaging problem. There's variability in skill, protocols, and workflow. And even when we do everything correctly, timing and fetal physiology still limit what we can do. The biological factors include imaging limitations. In the image on your right, I show you something called osseous or bone shadowing, where sometimes you can see holes in the septum. And this is because the bones of the baby are obstructing the view. But there are other reasons that are highlighted there. An important one is the detection of total anomalous pulmonary venous return. If you see this image, it basically looks like a normal heart. And in TAPVR, what happens is we see this very, very subtle feature called the twig sign, or a little teeny branch that doesn't connect the pulmonary veins to the left atrium. So it makes the diagnosis quite difficult in the fetus. The cognitive pitfalls include the satisfaction of search. This is the feeling comfortable with the four-chamber view, and you just say, I'm done with the diagnosis, or something that I came to learn in this presentation called anchoring bias. So what is anchoring bias? Anchoring bias is the tendency to rely too heavily on an initial diagnosis and insufficiently adjust in response to new clinical information. So an example is you have a patient with an increased nuchal translucency and you suspect likely aneuploidy. Because of that, you send a karyotype and turns out the karyotype is normal, right? So you forget about you think, oh, the karyotype is normal, and then you don't do anything else with the patient, and that's called anchoring bias. What happens in those patients is that you may be missing lesions that tend to progress during pregnancy. So anchoring will delay target fetal echoes or additional genetic testing. So it's an important pitfall. Being overconfident with the four-chamber view and not knowing other views is a significant cognitive pitfall that Sophia and I are working on a paper in Latin America on how to improve this. There are equity and equity issues that include the typical things. I'm again running out of time, so I won't spend much here. And I want to highlight the clinical consequences with this very important diagram. Here are two parallel timelines of the management of critical congenital heart disease diagnosed prenatally. On top, you see prenatal diagnosis, and on the bottom, postnatal diagnosis. We see that shock will present here when the patient is discharged and be after the patient is discharged and before the patient returns to the ER. And typically the cost is high because those patients after the duct closes will require a recovery from the injury of ductal closure and then going to surgery. Our group in San Francisco by my colleague, Dr. Peyvandi, showed that delayed care leads to significant issues. This graph, if you see prenatal diagnosis is in blue, postnatal diagnosis is in red, we see that delayed care after adjustment, postnatally diagnosed patients had their operations, their heart surgeries done 1.4 times faster. So sorry, pre-diagnosis, so diagnosis early leads to early interventions. So their operations were faster when compared to postnatally diagnosed. So how do we improve detection? By standardizing, by training and getting educated. And fortunately, in all of our futures, we have artificial intelligence tools that are going to help standardize and help have less misses. One important concept in this is redundancy. It is important to know that prenatal screening will detect some and postnatal oximetry screening will detect others. But the most important for neonatologists and pediatricians is clinical vigilance, right? Always have high indexes of suspicion and know that no single layer is sufficient. Prenatal screening misses some lesions, as I mentioned before, and postnatal pulse oximetry screening misses other lesions. And therefore, we end up having an overlap and a blind spot. This can be critical congenital heart disease can be evade both systems. So I mentioned the costs of false positive, and because I'm over time, I'm just gonna let you read those, but it causes quite a bit of strain and costs to the system. In the state of California, or what I'm trying to represent, a medium-sized country, the costs of having a false positive are very, very high. There's large absolute numbers of false positive. There's high costs of fetal echocardiograms and referrals for specialists, and it strains the system. The translation for a neonatologist or the clinician, the pediatrician taking care of those babies, the message is that know that normal prenatal screening does not exclude critical congenital heart disease, that there are lesions that have high miss rates and common things such as coarctation and total anomalous pulmonary venous return. You should keep a good clinical eye and maintain suspicion in the neonatal period. Know that pulse oximetry is extremely helpful, but will miss some lesions, and the concept of redundancy is essential. Lastly, the take-home messages from this talk is that detection with prenatal screening has high reach, but does not mean it has high detection. Screening systems should and are in high resource places complementary, but they are by no means perfect. Essential is clinical vigilance and high suspicions. Know that redundancy is necessary, and we should all design systems that anticipate some imperfection. And I apologize for going over. I did like 4 more minutes, and I will stop sharing and open for questions.
Thank you very much, Dr. Emilio Quesada, for your excellent presentation. We will move forward to Dr. Balu's presentation. I will share the screen for presenting him, but you can still ask questions. Remember to ask questions on the chat box.
Thank you, Sophia. I hope my screen is visible.
Doctor, I think you are seeing my screen, is it? Yes, Dr. Balu Vaidyanathan is a leading pediatric and fetal cardiologist based in Kochi, India. He serves as a professor of pediatric cardiology and head of the fetal cardiology division at Amrita Hospitals. He is known for establishing one of Asia's largest dedicated fetal cardiology services and has made significant contributions to training, research, and clinical care in fetal and pediatric heart disease. He has delivered over 550 lectures globally and published more than 80 research papers, playing a key role in advancing fetal cardiac care and improving fetal infant health outcomes. Now you should be able to share your screen.
Just a second.
Dr. Balu will talk to us about the challenges of large-scale prenatal screening programs, from evidence to implementation.
Thank you, Sophia. I hope my screen is visible now.
Yes,
Thank you. So thank you very much to the IPA and Dr. Sophia for inviting me for this wonderful webinar. And my topic is challenges of large-scale prenatal cardiac screening programs, from evidence to implementation. So at the outset, I would like to say that I have no disclosures for this talk. And warm greetings from Kerala, which is the southernmost beautiful part of India, sometimes called by people as God's own country. The contents of this lecture include, I will begin with the rationale for prenatal cardiac screening. Then we'll go through the current protocols and their effectiveness, which I call as the evidence. Then we will dwell upon the key challenges in the screening and implementation pathway and how technology like AI can potentially democratize the process of screening. Then we will talk about bridging the gap and how do you develop scalable solutions, in which I would like to discuss a model which we developed in Kerala. So CHD, as we are all aware, is one of the most common birth defects, and about 25% of them are critical. And a critical CHD is defined as the one that requires surgery or intervention within the first year of life. And these represent a major public health challenge with respect to high mortality in low middle income countries, as well as lifelong morbidities and healthcare costs in the high income countries. So this heat map actually looks at the contribution of CHD to infant mortality. And as we can see from this top row here, congenital heart defects, in the high SDI and the mid SDI regions, this is the second most common cause of infant deaths. Even in low and mid and low SDI countries, this is ranking high. So overall, congenital heart defects are the 5th most common cause of infant deaths all over the globe. So obviously, it's an important public health problem. Now coming to prenatal screening. Now, is it feasible? That's the first question, and several studies which are in the low risk populations from all over the globe, particularly from the developed countries like France, it has shown that it is feasible. However, there is very limited data from developing and low middle income countries like India about the effectiveness of a low risk population screening. There is no shortage of guidelines. Several societies have published guidelines like the American Society of Echocardiography, American Heart Association, and the very popular International Society of Ultrasound and Obs-Gynae, the ISWOG guidelines. In India, we have a Society of Fetal Medicine Practice guidelines for the mid-trimester anomaly scan, which includes the cardiac screening as well. Now, we know that following a prenatal diagnosis, we can look at even the heart as well as outside the heart. A comprehensive evaluation is possible. We can do genetic analysis. We can look at outcomes, and then we can prognosticate patients. And based on the gestational age, unlike a postnatal diagnosis, prenatal diagnosis offers much more options to the expectant family. You can go for continuation of pregnancy and delivery in a tertiary pediatric center in critical cases. In situations like fetal arrhythmias, we can go for in utero therapy. We can also do for very complex heart defects with many comorbidities like genetic anomalies, what is called a planned comfort care after birth. And in countries where termination of pregnancy is legal, some people go for termination when the underlying diagnosis is very complex. With respect to critical CHDs, prenatal diagnosis is a game changer. The families can be counseled and prepared in advance. There is no neonatal transport, which is great for developing countries, and it leads to better pre-op status and shorter pre-op ICU stay, translating into better post-operative outcomes and possibly long-term neurodevelopmental outcomes. So, considering all these benefits of prenatal diagnosis, many countries have gone for a national fetal anomaly screening program. And this is the results of the National Anomaly Screening Program from UK. This paper was published in the British Journal of Obstetrics and Gynecology recently. And in this, in the anomaly scan, the detection rates of cardiac defects were very high. The atrioventricular septal defect detection was 69%, HLHS was 92.7%, tetralogy 75%, and TGA 85%. So this is an ideal situation where there is a healthcare system and there's a protocol for screening for fetal anomalies. There's a screening program, and hence there is a continuous process of training, auditing, and hence the detection rates are very high. This is another important study which was published in 2019 in the British Medical Journal. And this looked at the prevalence of critical congenital heart disease from an international perspective. And this 12 countries participated in the study, and this included 15 birth defect surveillance programs and included a total of 18,000 CHDs. And there was a massive difference in the detection rates between different countries. In countries like France and Italy, the prenatal detection rate for CHD was 87%. However, in other countries like Malta and Slovak Republic, the detection rates were low, and most of the cases were diagnosed postnatally. And when you look at the lesions also, there is a difference in the detection rate. The last column looks at the overall detection rate, which was 87% in France and 13% in the Slovak Republic. For conditions like hypoplastic left heart syndrome in the high-income countries, the detection rates was almost universal, but only 25% in the low-income countries, while for TGA and tetralogy, pretty much similar patterns. So what I'm trying to say is that the detection rates completely vary where you are practicing in the world. It may be very good in the system in countries where good established systems, while not so good in other areas. So we know the evidence. We know that prenatal diagnosis is possible. We know that it is feasible to do screening in low-risk populations. It has been shown. We know that a lot of good screening programs will pick up CHDs. We know that prenatal diagnosis gives more options and it can improve outcomes in critical CHD. But in real life practice, what we do, we miss most of the CHDs in prenatal screening, especially in the low and middle income countries. So what are the core challenges in prenatal cardiac screening? And this is applicable everywhere, but especially true in LMICs. We can classify them into 3 levels: the pre-scan level, the scan level, and the post-scan level. At a pre-scan level, we are looking at a needle in a haystack. Basically, even though CHDs are the most common birth defects, but they occur with the prevalence of perhaps 1 in 100 for all, and maybe 1 in 1,000 for more severe forms of CHD. So we have a low pre-test suspicion. So we need to screen a large number of pregnancies to get one case. 80% of the CHDs occur in low-risk pregnancies. So mother may not have any risk factors. Then there is this timing paradox. When do you screen? Early screening is ideal, but early screening will end up missing more cases. And then there is this big issue of coverage gaps, the rural versus the urban divide. In many parts of rural India, the prenatal screening for congenital heart defects are not at all available, and most of the expertise is in the is in the cities. At a scan level, there's a difference in equipment quality. That's pretty much glaring. Operator dependency, because not everyone is properly trained towards cardiac screening. And then, obviously, to make matters complicated, the cardiac anatomy is three-dimensional. It is dynamic and it is indeed very tiny. So obviously, it makes it extremely difficult for a non-trained person to screen the fetal heart. And as Emilio said, fetal position, maternal BMI, and then late gestation, all these factors can contribute towards difficulties at the scan level. At a post-scan level, the referral to fetal cardiology is often not available in many parts of the LMICs. The counseling quality varies, and as a result of this, the decision-making processes and timelines often are very complicated. So the statement which I wanted to make is that guidelines do not scan patients, but people do, and this results in gross inequalities. This is an important paper which is published in the Obstetrics and Ultrasound in Obstetrics and Gynecology in 2020, a study from the Netherlands, and they looked into the reasons why congenital heart defects are missed in prenatal screening, and they found out 3 reasons. Poor adaptability on the part of the sonographers, resulting in inadequate images in 49% cases, inability to recognize an anomaly in the recorded images in 31% cases, and perhaps an undetectable CHD like a coronary anomaly or maybe even coarctation, and that you can do nothing about it. So in 80% cases, with proper training and auditing, it is possible to actually diagnose CHD, which is perhaps an ideal figure. And many countries like the Netherlands and France have actually reached that level now. Now, in addition to the scan level challenges, we have a lot of implementation level challenges also. So at the workforce level, we need a large number of trained sonographers, which is not so easy. And you need to constantly check their competency, you need standardized training protocols, and you need accreditation programs. And for the quality assurance, to make sure that the recordings are properly reviewed, you need dynamic loops, centralized storage, and then you need standardized reporting. And to make things into a right perspective, you need a proper linkage between prenatal diagnosis and postnatal outcomes, which never happens in many programs in countries like India. The ethical and legal challenges include the variable counseling, especially by non-cardiologists, parental decision-making, which a lot of cultural factors come into play, which Rima is going to discuss next. The rules for termination of pregnancy is completely different in different countries in the globe, and hence the access to postnatal care is different, and the healthcare financing is also a big challenge in many places. These are the reasons why the evidence to implementation gap still persists. The imaging protocols are, even though we know that the 4-chamber with outflow tracks is superior, only 4-chamber is done. Training hardly happens because of underfunding and many other reasons. Quality assurance is still utopia, data systems are absent, and referral to fetal cardiology services happens only in very, very few places. And as a result of which, even though the diagnosis is made, access to a specialist is not possible. So most of these are not because of a gap of knowledge, but as Emilio said, inertia in the health systems and resource distributions. Now, this is a classical example of a maestro who actually bridged the gap between evidence and implementation. Kipros described nuchal translucency way back in the early 2000s at 11 to 14 weeks. And then what they did was they actually conducted several certification courses, as a result of which even in a small center, scanning center in India, this is practice. So they bridged the gap between evidence and implementation. But NT is something which is easier to do compared to the cardiac screening. So similarly, to bridge the gap from evidence to implementation for fetal cardiac screening, we need the following steps. We need standardized screening protocols, We need mandatory training and certification. We need centralized data collection, and we need to integrate prenatal and postnatal services. And this has been successfully done in countries like Netherlands and the UK. And in Netherlands, they published the effect of doing all the above steps on the pickup rates of TGA and tetralogy, which is more than 80%. Now I come to the specific scenario of low middle income countries like India. Massive variations in the diagnosis, 25 million births every year, and so many limitations and expertise is available in a few centers. So the person living in a small town hardly gets access to a high-end fetal cardiology program. And we have 250,000 CHDs born every year, of which a huge number requires surgery. There are certain parts of India which are shown by the red highlight. There, the infant mortality rate is more than 40 per thousand live births, while in certain other parts where I live, the IMR is actually very, very low. So I come from Kerala, which is the southernmost part of India, and we have an infant mortality rate of 5 per thousand live births. And this remaining part of the presentation is a story of how this has been achieved. The access to antenatal care is very important, and in Kerala it is universal. And unlike many other parts of India, we have 7 centers offering pediatric cardiac care, of which 5 of them are in private, and there is a very good private-public enterprise going on by which any child born with CHD can access any program and get free pediatric cardiac care. The first step was identification of the problem, and this was done way back in 2015 when the Indian Academy of Pediatrics published this paper suggesting that congenital anomalies, especially the congenital cardiac anomalies, were an important contributor of infant mortality in Kerala. And this paper, which was subsequently published in the Archives of Disease of Childhood, it is a registry of neonatal congenital heart disease in Kerala. About 1,500 babies were included. In this, even though a lot of patients were identified by pulse oximetry, a lot of babies died in the first month of life. And the pre-operative mortality was the reason for 86% of the death. So the newborns were dying not at the time of surgery or after it, but they were dying before they underwent the surgery. And this study concluded that the primary screening, the prenatal and neonatal, needs to be strengthened. So then we sat and identified what are the components which is required to form a fetal cardiac network, which I call the fetal cardiac chain. You need to integrate all of these. You need antenatal services which were available in Kerala. You need to sharpen the systems for prenatal diagnosis of CHD. You need to develop an in utero referral network. You need to have centers for pediatric cardiac care, which are already there. And then, of course, to create the funding support, etc. And these were the weak links in the chain which we thought we should work on and strengthen. That is improving the detection rates, creating a network, and then the funding support. So we developed a service which was started in 2008 and serially was scaled up towards current division, which is now a multi-specialist. It consists of multiple specialists from fetal medicine, fetal cardiology, genetics, and all the postnatal departments are integrated into a truly multidisciplinary center of excellence in fetal care. We have databases and follow-ups which helps us to tell what happens to these patients. And this is our fetal heart team, and we work towards getting the diagnosis, counseling, and a comprehensive evaluation of all fetuses with CHD. We went about the whole state, educating people on awareness about CHD, and also we trained more than 600 doctors, mostly the obstetricians and radiologists, on actually how to do the prenatal screening for congenital heart disease. We developed these flashcards, which included all the views which are required for fetal cardiac screening, and we trained them in all these views. We also provided the doctors with a resource booklet for fetal cardiac evaluation, including the downstream action plans once you diagnose a congenital heart defect in the fetus. And then a paper was written on the effectiveness of these training programs. And 96% of the people who responded showed that they were comfortable in getting the 3-vessel view, which is critical. And 78% were comfortable in the outflow tract views. All participants reported increasing number of fetal heart screening after the workshops. And within a matter of 1 year, more than 200 cases of critical fetal heart defects were registered in the government portal. And this directly, what we did was we increased the prenatal screening effectiveness, and then we integrated prenatal services with the obstetric service and the postnatal care. So it works in a completely seamless manner, like what happens in many fetal cardiac programs in the developed countries. So what happened, and this is the data on the outcomes. Since inception, we saw a steady increase in the number of referrals every year, and the number of babies with critical CHD which was born in a tertiary center, in our center, increased. Since inception, we have delivered more than 800 babies with critical heart defects in our center. In this paper, which we published in the Cardiology in the Young in 2019, we showed that prenatal diagnosis can have a significant impact on the preoperative status of patients. And this was statistically significant in all the critical CHD groups: the duct-dependent systemic circulation, duct-dependent pulmonary circulation, transposition, as well as other CHDs like TAPVC. The California TRIPS score for transport stability was also better in the prenatally diagnosed group, achieving statistical significance in the duct-dependent systemic circulation group. So we could show that with a program which is developed through training, education, and in utero referral network, we could show the impact on the preoperative condition of these babies. This is another paper which we published in 2021 in Ultrasound in Obstetrics and Gynecology, which is the benefit of prenatal diagnosis for babies with transposition and intact septa. We had 82 patients in this cohort, of which 64 were born alive, and majority of them were born in specialist centers. And there was only one preoperative mortality and one postoperative mortality in the prenatally diagnosed group, which is being born in the specialist center. And we could show that prenatal diagnosis and a planned delivery in a specialist center is remarkably life-saving in patients with TGA. And this is a protocol which we follow in Kerala these days. Any TGA which is diagnosed gets referred to a pediatric cardiologist, and the delivery happens in a tertiary pediatric cardiac center. The mean age at surgery was 4 days in the prenatally diagnosed cases, and the postoperative mortality for TGA for prenatally diagnosed cases was 2% compared to 3.6% for postnatal cases, which achieved statistical significance. So clearly, there is an improvement in the outcomes. And what is more interesting is that we also showed that the overall cost of cardiac care was lower in the prenatally diagnosed case, including the cost of fetal echo. So the direct cost, which includes the cost of fetal echo, the indirect cost, which is the stay for the family, and the total costs were lower in the prenatally diagnosed group, especially for the surgical group, by as much as 20%. So this is an added advantage that we are getting better outcomes at a lower cost. And what happened at a community level is that we integrated this entire program of prenatal diagnosis with the universal healthcare for children for CHD in Kerala. This is called a Hridyam scheme. And there was a 41% reduction in the CHD mortality. And because of these efforts, Kerala achieved a single-digit infant mortality rate in 2018 of 8 per 1,000 live births, which has come down to 5 per 1,000 live births in the current era, which is a very, very major achievement for the state. And this is a model which has been working well in the state for the past 1 decade. Now, many other states in India are trying to develop this model, and in the 5G era, we can easily develop an interconnected fetal network. So I talk about the primary level, which is a screening for CHD at the level of obstetricians and medical officers. Then a secondary level where the diagnosis, counseling, and referral is done, which is the fetal medicine specialist and the radiologist. And then the tertiary level where the care is provided. The key thing is to connect these three groups, and this can be done using telefetal echocardiography, AI-based training, and remote diagnosis and capacity building. And this is exactly what we are trying to do in the current times. One slide about artificial intelligence in fetal echocardiography. A large number of studies are now, about 75 papers have been published in this field. AI has been used to enhance the diagnosis by assisting the anomaly scan. AI has been used to automate an assessment, classify, annotate, and measure various fetal cardiac structures. And in a recent paper, which is published in Nature Medicine from Rima Arnaud group, they used ensemble of deep learning networks to provide expert level prenatal detection of complex congenital heart defects. However, there is a paucity of studies in the level of the population. But it is expected that artificial intelligence can play a very big role in a lot of aspects of the fetal cardiology chain, and it can potentially enhance the accuracy of the diagnosis, reduce operator variability, and can potentially improve outcomes. So in the next decade, we are likely to find a lot of studies in this regard. So some of the research directions, especially pertinent to the low middle income countries, include the development of scalable and cost-effective training models, especially simulation and telemonitoring, validation of the AI-assisted screening tools across diverse populations. The Fetal Heart Society has already initiated such a study. The longitudinal studies linking prenatal detection with neurodevelopment and quality of life outcomes, especially in LMIC settings. And then evaluation of screening strategies and LMICs, which is grossly lacking in major studies from the low middle income countries like India. So I would like to acknowledge the role played by my team, which is the pediatric cardiac team of Amrita Hospital, Kochi, a stellar program in India for the past 25 years. And I think it's the integration of the prenatal services with the high quality postnatal pediatric cardiac program, which helped us to achieve this results in Kerala. Thank you very much. And I am open to questions and doubts.
Thank you very much, Dr. Balu, for your insightful presentation. I will now, just a minute, Rima, so I can introduce you. If you stop sharing the screen. That's it. Dr. Rima Badr is our next speaker. She is a professor and senior consultant in pediatric and fetal cardiology, board certified in pediatrics and pediatric cardiology with a doctorate from the University of Bonn, Germany. She completed advanced fellowship in fetal cardiology at SickKids in the University of Toronto, Oregon Health and Science University, and the University of South Florida in the USA. She is the primary author of the Prenatal Cardiology Handbook that has around 30 peer-reviewed publications and serves as president of the Fetal Gulf Heart Association. She is vice president of the Women's Heart Saudi Association and the organizer of the International Fetal Cardiology Series under the Congenital Heart Academy. Thank you, Rima, for joining us.
I'd like to thank you for this. I'd like to thank Sophia for this beautiful introduction, and also I'd like to thank the IPA for organizing such a thing. And I'd like to wish the whole world, as a pediatrician, as Dr. Haddad said, we want peace for our children, for the children of the whole world. Hopefully this crisis will end. I'm going to talk about the title of the talk that was given to me, and it's a question that can cultures and religion affect the acceptance of prenatal screening of congenital heart disease. I'm talking about Saudi Arabia and most of the Middle East. I have no disclosures. And
Rima,
I just wonder.
Sorry for interrupting.
Yes?
We are not seeing your screen. You are not sharing.
Oh, okay. Why? I'll share again. Sorry. Okay. Share.
You started, but then you stopped. Now it's okay.
Am I okay? Now okay?
Yes.
Why did
Yes,
it
thank
stop?
you.
So as I said, I have no disclosures, and I just want to share with you the importance of prenatal diagnosis. So prenatal diagnosis is very important because it allows perinatal planning, i.e., where to deliver and when to deliver. As practicing fetal cardiologists, we know that there is a very high rate of cesarean section in many countries because the obstetrician fails to face the diagnosis of congenital heart disease. So they want the baby out as soon as possible. And so we have a higher rate, as in Saudi, we have a higher rate of cesarean section, maternal morbidity, maternal mortality, and a lot of costs in ICU and ICU for adults, and lots of problems just because we didn't do proper planning for after diagnosis of an anomaly, basically congenital heart. And of course, we can deliver in cardiac centers. As cardiologists, we all know that a baby that goes stable to the cardiac surgery is going to have a much better result for the operation. So stabilization in utero is the best option for us. So the baby will just be in the best care in the uterus and delivered in a tertiary care center after planning time of delivery and mode of delivery. And most of the babies with congenital heart disease, apart the ones in heart failure, will be able to pass vaginally through the birth canal. And we have something called the cardiovascular profile score, and this is by Dr. James Huta, my ex-mentor. And if the score is below 7, probably they cannot do it, i.e. heart failure will be the only, most probably, a reason for not delivering a fetus vaginally. Now, neonatal stabilization, as we said, very important. Acidosis, and we know that also fetuses antenatally, especially the ones with cyanotic heart disease, their brains already suffered in utero. They used to think that the bypass and the cardiac surgery can cause, and it does, but with all inventions and the progress that we had, they used to think that it is the reason behind minor learning problems and developmental issues that the babies have after being on cardiac bypass. But later on, they knew that in utero, the flow and the progress of the brain is affected specifically in the cyanotic heart disease. So baby is born already with an abnormal, relatively abnormal brain, and you want to stabilize the baby because of hypoxia. You don't want the acidosis and the sequelae of acidosis. And we know that early surgery, and this is an early surgery, of course, for certain operations like the hypoplast and the Fontan pass, where you do the stage 1 operation at first week or so, or 10 days, or transposition. So it depends on the surgery. And most surgeons would like to have a baby stable with good weight. So now if we're talking about prematures that are 2.5 kilos, not all centers would take them for surgery. Okay, do you hear me? Sophia, am I okay? Okay.
Yes, everything's fine. We're listening.
Screening methods. We know that as our colleagues, Dr. Emilio and Dr. Ballo mentioned, there is a screening methods and detection rate. And I enjoyed what Dr. Emilio said, that screening does not always fulfill detection. But anyhow, screening methods, usually in the second trimester, anomaly scan, that's 18 to 22 weeks in most countries. And then you do fetal echocardiography as a next step. And genetic testing is very important nowadays, especially in our countries where we have high consanguinity rate. And the incidence of congenital heart disease worldwide is about 8 per 1,000, while in Saudi, many papers has been out in many centers, but I cannot say this is the whole country, but it's about 12 to 15 per 1,000. So it's very important. Now, we have a detection gap, as Dr. Balu mentioned, and it's lots of things. It's not just money or knowledge, it's many things. So the detection rate, as Dr. Balu mentioned, that France has a very high detection rate. They have a very good and robust screening protocols and management. So it's 60 to 70. Of course, the cost that I think the government pays for all screening in France. Israel has 65%. Gulf region is 0 to 30. We don't have in the Gulf area yet a protocol that would allow all women to go for screening. Of course, in private hospitals, those who can pay will have screening, and these are okay. But we're talking nationwide. We don't have a screening program. Some of the Emirates are doing that. So we are developing the screening program. Hopefully, we have a higher detection rate nowadays. The lower resources countries is also very limited because, if you don't find food to eat, how are you going to go for fetal echo, which is most of the time the trainees in fetal cardiology, the good trainees, are not too many people. Now, the global burden of congenital heart disease, as you said, it's most common congenital. Normally, when I do scan and when I do counseling, I tell the parents that the heart and the brain are really the most important ones, because you want to tell them why they're here. Of course, some of them know before they come, they read our leaflets, what we do before the visit, but some don't know. So we tell them that you're trying to help you throughout your pregnancy by detecting a lesion that can hurt the pregnancy somehow. As you said, the prevalence is 8 to 10 per thousand. In Saudi, it's more. For sure, it's more. And we don't have it documented, but it's 12 to 15. And then it's a major cause of infant morbidity. And I think also statistically mortality, specifically if we combine prematurity with congenital heart disease. Now, what are the factors that are controlling detection? Why are we not detecting the whole world? This is about 40 to 60%. And what Emilio showed that in the U.S. the detection is getting higher and higher, which is very promising. But U.S. is not the whole world. We have different places that we need to learn from those successful countries and implement what we think, as Dr. Balu is successfully tried to do in south of India. Now, it depends on the training, and training is a big world, really, and not every training is training in my world. You have to have proper training. I mean, you have to have a system, you have to have structured training, and you have to have good mentors. And then you have to have screening programs. So this means that you're trying to get them 18 weeks to 22 weeks. I've scanned ladies with 36 or 7 weeks because they missed the early scanning, early anomaly scan. And of course, we have to have a referral system, the route, the pathway, because you can, as Dr. Bali showed it, they can be diagnosed, but they're not referred because there are no resources. They come from different places, far away. The consultant or the Center for Fetal Cardiology or Cardiac Surgery is far away, and so on. And also, I've enjoyed listening to Dr. Emilio about the false positive case that in the U.S. that was there, and how much money was, although with all the referral system, because in the U.S. they have a really good referral system based on the availability and based on the medical legal aspects of missing cases and so on. So also you don't want to have a false positive, but also you have to have a good referral system. Now, what is culture meaning? For the West, it's a reproductive choice, means how many babies you're going to get. And some couples don't want to have any babies anymore. And some would love to. I'm from Europe. East Europe is different from Western Europe, and North America is different from South America. And so in the Middle East, it's a family consultation. Middle East usually is a very warm society with lots of love and care. And we hope to keep this. This is culture and meaning. So all the world have good hearts, and we all love kids, and we all love children, regardless what's your background. But the thing is that how are you going to be good to your kid, and in what way? You want the baby to be born in the best environment. You want the baby to have the best surgery. You want the baby to have the best post-operative care, and so on. So here's the culture. The nidus is there, but how we use it is important. Now we have in the Middle East, this is diversity. We have Islam, the majority, Christianity, and Judaism, and others like people who don't have any religion or sects and so on. From an Islamic point of view, that of course medical treatment is encouraged, and especially in antenatal, postnatally. In Islam, it says that your soul is a present from God to you, and you have to keep it. You have to really look after it. So if you don't really go to the doctor, if you don't plan to get treatment, and you can, it's like a sin in Islam. So, I mean, the other thing is that can we get rid of bad fetuses? I mean, with deformed fetuses, Islam allows that, which is the Sharia is the Islamic law, allows abortion, legal abortion below 120 days of age. However, it's not a free abortion. It's localized by by laws from the Sharia in most of the Arab countries, Islamic countries. It's by law, it's 120 days. Some people say with 90 days, but the majority accepted 120 days. And which lesions can be terminated? Whatever lesion that la yurja bur'u, it means that it's not going to be good for life. Of course, the major ones, and of course, like anencephaly and so on. But it's coming up now. We didn't have a lot of terminations for Down syndromes, but now I can see that a lot of couples are asking for terminations because it's a lifelong burden, and it is allowed as well. So we have a door in Islam is called ijtihad, which is the door where religious scholars sit and discuss the updated problems and try to get answers. And I think it's in every religion as well. I'm not sure. So as we said, in Islam, it's before 120 days. In some other 90 days, but majority is 120 days. From the Christian perspectives, of course, we have Orthodox, Maronites, and so on. And the screening is accepted and termination is discouraged. Of course, and I understand that termination is discouraged in all major religions, thinking that this is a gift from God, and they don't allow it. But as I know, as a Muslim, I know that in Islam there are lots of ways that you can get approved for a termination after having 3 consultations and after proving that this is going to be either dangerous to the mother and or a baby is not going to be fit for a normal quality of life. For example, hypoblasts and so on. And from the Jewish perspectives, there's Orthodox, conservative, reform, and genetic screening is supported. So you do genetic screening because also in some Jewish communities, there is a lot of consanguinity as well. Now, ethical comparison, Islam screening is accepted, so it's not even forbidden. In some religions and some sects, think of screening. Are you questioning what God gave you? Which is very strange, because what God gave you could be a test for you as well. It could be a gift and could be a test. So in Islam, screening is accepted and encouraged. In Christianity, screening accepted and is strongly supported. Now, consanguinity in Saudi and in most of the Middle East countries, specifically if you go away from the central parts, rural parts, consanguinity is quite high. First-degree cousins and so on. And in Saudi, we have tribes, of course, and we have also tribal diseases, especially the metabolic ones. So we have a high rate of consanguinity, and we have 40-60 in Qatar, 54%, and UAE 39. Saudi, we are almost like 32 million, so the rate is quite significant. Well, Qatar and UAE, the population is not that big. Now, disease burden, of course, the disease burden is not just on the mother, it's on the society, on the system as well. Now, also, if you want to do it properly, you have to have a system, you have to have proper training, you have to have proper resources. Everything has to be proper. So it means the increased fetal cardiology demand. And as I said, fetal cardiology is not the same as pediatric cardiology. Pediatric cardiology, we're all pediatric cardiologists, as we're all pediatricians if we're board certified. But fetal cardiology is an extra training in pediatric cardiology. So we need those to be more in every place because they deal more with the antenatal diagnosis and putting a plan of management and also treating in utero. Now, in Saudi, we are lucky to have really fetal medicine programs that are very good, and fetal and premarital screening, which is very, very important. You're not allowed to get an OK certificate to get married unless you do screening for certain diseases. And then we're trying nowadays to put the screening with the help of the Ministry of Health to increase the screening put a system where the soldiers, as I call them, or the technicians or radiologists or obstetricians that are facing the pregnant ladies have good training in doing the 4-chamber and outflow tracts at least. Because if you do the 4-chamber, you get 60% detection. If you do the outflow tracts, you get 80% detection. Regarding the 3-vessel view, it's good, but personally, I was burned by it. You have to know, if you have a 3-vessel view, you have to get the outflow tracts from the left ventricle to the aorta, and from RV to the pulmonary. You have to follow them, and this is what Norman Silverman told me personally when I discussed this with him. And I'd like to share this experience with others. And then you can easily miss transposition if you're not really good in 3-vessel view, is to follow the great artery coming out from the corresponding ventricle. And counseling, of course, when you counsel, you have to put in the religion, what the religion allows, and what religion does not allow. Of course, you don't know all religions, but you try as much as possible to respect the couple that are coming and ask them if they ask you, because most of the time the couple will ask you, what would you do if you were in my position? And of course, the answer comes back, I'm not in your position, it's your own decision. And the prognosis is very important. Will my baby have a normal life after surgery? What type of life? If we're doing a hypoplas, we say this is 3 operations, and there's a Fontan is not a very, very nice one, depending on the center, but generally is not something nice to have for the rest of the life. But of course, it's an option. Suffering, yes, suffering from a lot of admissions in the hospital, from missing school days, from the burden for the mother to leave other kids and stay in the hospital with a newborn, and the burden. I always feel, actually, my heart sort of breaks to the mother with the mothers that are pregnant with babies that are with complex heart disease like hypoplast, or and as we say, hypoplast is a spectrum, but the bad hypoplast, because she comes late, she's not going to have an abortion. And she comes late and she has to wait till she's 37 to 40 weeks. So all this period of her carrying this baby, we need to give her a lot of emotional and psychological support. I always talk to the couple, and I also talk to the husband one-to-one, saying that she's the one who's carrying the baby, and she's the one who's crying at night, and she needs a lot of support. She needs your support, your approval also, that she is carrying a baby that's not good. And decision, what are you going to do? So this is, as you say, first of all, you have to have the right diagnosis, because as Emilio said, the baby didn't have anything. She has AP window, and then postnatally it didn't have anything. Also, coarctation is something that you can easily miss antenatally, especially the subtle ones. But you have to have the proper diagnosis. And as my colleague said, the easiest is hypoplas, and the worst prognosis is hypoplas. So, and then you counsel them in a separate session, and I counsel more than once, because the first session usually is a traumatic one in our culture, and she keeps crying, and so they bring them back again. I do the counseling myself, and then of course we ask for the genetic counselor in the second step. And then a family consultation, they want to know recurrence risk, and so we do a lot of NIPT and micro-IA and West nowadays. So our framework of counseling is the diagnosis, your faith, your belief, and the impact on the family, because 3 surgeries is going to have a lot of impact, energy-wise, emotional-wise, and money-wise. Not everybody have someone to pay for the surgery. As our colleague said, this AI-assisted ultrasound models are nowadays in many machines, so we can easily detect a lot of anomalies, and at least basic ones, and then you refer to the fetal cardiologist. And so what it does is you put a point, and then the machine will trace the heart for you and give you, instead of really trying hard to get a proper 4-chamber view, because the most important one is the proper 4-chamber view. And then the outflow tract, the machine will do it for you. So this might help us quite a lot, provided you have the proper model. We have in Facebook, if you like to join us, it's an educational channel. Now, I'll just take you for a clinical history. I've talked a lot about the ethics, I'm talking a lot about the belief and the culture. Let's go to real life. As we said, the fetal cardiology talks about anatomy, rhythm, ventricular function, and we don't miss the extracardiac association, because it affects the heart, it affects the outcome, it affects the function, okay? And the screening views is 3 vessels, 4 chamber. We've spoken about that, and 3 vessel trachea views. These are beautiful landmarks in the history of detection of fetal hearts, abnormality in fetal hearts. Now, it just basically you try to get the ratio in this. You try to get the ratio. The heart has to be 1/3 of the cross section of the diameter. So, and 1 to 3, this is a normal. Bigger heart, probably a sign of heart failure or cardiomegaly or cardiomyopathy. Now, looking at this here, as we said, you have to have a proper 4-chamber view, and this is the most important one, where you see the offsetting of the tricuspid valve towards the apex, and this is the RV, and we don't know this is the RV because it's anterior or because it's the LV is posterior next to the spine. In cardiology, we don't do that. We look at the morphology, we look at the valves, where are they attached, and we look at the moderator band and the right ventricle. So there should be a moderator band, so this is RV. Now, and then you look at the outflow tract. As I said, to check this is RV, and what's coming out of the RV is the pulmonary, and what's coming out is probably the aorta, but you have to see the arch and you have to see the branching. And you, as we said, you put the no color, and here you see the size, and that the LV is apex forming, and we see that this is LV, this is RV, and this tricuspid valve, a little bit of offsetting towards the apex, so this is RV, and this foramen ovale, so this is the left atrium, and then you put the color, and you can easily say that, and after putting the color on, there's no VSD here, at least in this view. So this is the basics of fetal echo, and then we do the ductal arch, and we do the 3-vessel view, which is PAS, pulmonary artery, aorta, and SVC, and then you get a ductal arch, where no neck vessels, and then you do the aortic arch with neck vessels. So this is basically what you should get. So this is a story, 26-year-old pregnant lady, came at 22 weeks for a normal scan. She was diagnosed with hypoplastic left heart syndrome. So, I mean, first of all, you get the diagnosis, you tell them, and I always believe that you should draw diagrams to the parents, and I've enjoyed, when I was in training, looking at seniors drawing, and drawing makes really breaking the bad news an easier point, at least from my point of view. And then when you come to the management, you talk about management, and then religion or faith or culture comes at the end of the discussion. So this is what what looks like a hypoplastic. So here you have one ventricle, easy diagnosis, one ventricle. There's another one which is very small. So this is a single ventricle. With the right or left, it doesn't matter for you. Just it's a single ventricle, and you look at the relationship of the great arteries. So this is a single ventricle, which is most probably an LV because of the way of the morphology. But then we go and do a three-dimensional. So this is non-apex forming LV, and this is a small aorta, and this is an RV. What we do here, also we do a 3D imaging because we were told it's a hypoplastic ventricle. So is there another ventricle? Yes, there is another ventricle, but it's not functional. So it's a functionally single ventricle, but anatomically there's a shy ventricle hiding below. So this is a single ventricle physiology and not anatomy. So we tell them about the surgery. You have 3 surgeries, and we said quality of life. The girls are getting married, not getting married. They're going to have children, not children. The chances of cardiac transplant, the breakdown of the fontan. You can tell them, but not in all. I believe you don't tell them this in all one setting. We have to sit with them at least twice, from my point of view. In another case, this is a 47-year-old lady, gravid at 8, multi-gravid at 23 weeks gestation, referred for an abnormal scan. Early in pregnancy, she has an NT of 6 millimeter. NT is something that they measure in the first trimester around 9 to 11 weeks, and it has direct correlation with the incidence of congenital heart disease. So the higher the NT, the higher the incidence of congenital heart disease. So these are indications: the age of the mother, which is a little bit out of range, and the multiparity and the abnormal NT. So what did we see? We see an atrioventricular septal defect. And what is an atrioventricular septal defect? It's a deficiency in the atrial septor and deficiency in the ventricular septum and one common valve. Okay, so easy diagnosis. But then you put the light on, and you have to know the color on, and you have to know if there's AV valve regurgitation or not, because the prognosis and the follow-up and number of visits depends on the size of the ventricles, the outflow tract, and the regurgitation. Now this is what a normal heart would look like in 3D. So not like what we just saw. We have and the 3D means that it's like we look deep into the ventricles. So I've just shown you. This is the 2D, and this is the 3D of the AVSD. So if you look here, there's a little bit of asymmetry of the ventricles. So the LV is smaller than the RV. It worries you that you have to check the aorta. We call this unbalanced AVSD, and then we do the 3D, and with the 3D, you can easily go in depth and see that really there is a difference. And this is the gooseneck deformity that we see, unfolding of the outflow tract. We see that in cardiac cath for AVSD. It's a hallmark. So what are we going to do? We're going to continue pregnancy or palliative care. And so the rule is that if it is below 19 weeks, parents don't want to keep the baby, they can get a legal abortion in Saudi, in most centers. After 19 weeks, they cannot. So what are we going to do? Specifically, if the trisomy has heart disease, so where are you going to deliver? If there's balanced AV canal with no eval regurgitation, it could be in any hospital, and outflow tracts are okay, and then they can be referred. They have to know that there will be surgery. At what age? It depends on the clinical signs and symptoms post-delivery. Also, we tell them that nowadays there's early intervention programs not nowadays, actually for quite some time, that those babies are going to be a blessing in your life if you like to keep the baby. And meanwhile, it's a lot of work for the mother and the father. Most of the dames, I've seen them, really, I've found that they're really loved by their parents, and specifically their sibs. They like them and they love them. And there's a lot of training, and I've seen really a big jump. We have something called Health Center here in Jeddah, and the ladies in the center for 20 years have done a beautiful job in making those children independent adults. So the take-home message is understanding and respecting the cultural diversity improves patient-centered care and possibly long-term outcomes. Congenital heart disease is the most common congenital anomaly, so it's serious. You have to detect it. Prenatal diagnosis improves neonatal outcomes. Improves also the money spent by the government on the cases. You can spare about 40 million at least per year in our country if you do proper prenatal screening. Decision making reflects medicine, faith, family, and interaction. We have all the three together. These are the references, and you can follow us on the fetal series. We're going to have a beautiful. On the 29th of April, we're going to have a discussion of the fetal echo guidelines with gurus of fetal cardiology worldwide. Thank you.
Thank you, Rima. It was a beautiful presentation. We will now have some time for a Q&A and for discussion. The three presentations were really amazing. We will start. I have questions for the three of you, but I will start reading the Q&A chat. Dr. Atikur Rahman Khan is asking Rima, I imagine, about the role of perinatologists in Saudi Arabia, and also he's asking about perimarital investigation.
We have a very good, we have actually in Saudi, most of the maternal fetal medicine, 90% were trained in Canada, worldwide now, in Saudi, because the government have been sending postgrad for the past 50 years. So at least we have and a lot of maternal fetal medicine specialists, honestly. So the care is relatively okay if you are living in the area where those specialists are available. The problem is in the outskirts. So that's where programs should address the outskirts. And we are hoping with the government to reach this solution. The premarital, we have a system by law since 15 years. You have to do certain tests before you get married to get the approval for marriage.
Thank you. The three presentations were excellent. I think they complement each other, getting very concepts very clear. I'll start by asking Emilio, you showed us the costs of false positives and false negatives in prenatal congenital heart defects detection. Are there national health care policies addressing training? You showed us also a big difference between MFM and OB images rate detection.
Yes. I'm sorry, I missed the question.
Are there national health policies addressing the training and the differences in training? How do you improve training, general training? Because you can't have lots of MFM specialists. It takes a lot to train them. Money
Yes,
and time.
absolutely. Thanks a lot. So I don't know of any policies involving training. The gaps in, for example, this country of the state of California, right, is quite significant. To give you an example, I work for the university in San Francisco, right? But I work also in an outreach clinic that is 2 hours south in a community called Salinas, California. And in a span of 100 miles or 160 kilometers for the rest of the world of us, I see such different gaps, right? In San Francisco, you have MFMs that are outstanding, excellent diagnostic with, like you said, significant years of training. And 2 hours away, we have people that completed radiology with basic prenatal ultrasound training. So within a 160-kilometer range, you have people that have never trained on viewing the fetal heart, and you have a lot of misses. In my career here in Salinas, have had multiple cases that are babies being born, and they're critically ill, significantly cyanosed, and coming to find out that they have undergone 3, 4, 5 prenatal ultrasounds. And all of the reports I have presented to quality improvement projects on, the reports typically say we can't see the fetal heart, return in 1 month for an ultrasound, and this just repeats itself. And quite impressive that including here where you have referrals within an hour of a drive, those patients don't make it to the fetal cardiologist. So I think to your question, we might not need more training of maternal fetal medicine specialists, but maybe the basic training on radiologists and obstetricians on having a short week for referral, right? So knowing your screening views, which is the highlight point that we were saying about knowing those guidelines. And if you have any abnormality or you can't see the heart, just refer. So then again, I think in Argentina is a similar situation, right? Like instead of the small practice private obstetrician keeping that patient and trying to diagnose it, referring it as soon as possible, I think that would increase. That leads to sometimes false positives, which I highlighted in this country, very expensive, but that's the risk of trying to get a proper diagnosis, right?
Yes, in Argentina we have lots of false negatives, also false positives, but more false negatives are a worse problem. And as you said,
as well. I would say, sorry to interrupt, Dr. Grinenko, but I think California is the same. We still, vast majority of coarctations and tetralogists, and including for example, conotruncal abnormalities are postnatal diagnoses. We're getting better, but I think it's not yet there.
Yes, as you said in your presentation, we are working a lot in the Argentine Society of Pediatrics to try to improve and to integrate prenatal with postnatal, including the oximetry, the pulse oximetry test, and the clinical. That Dr. Balu also focused on that, the importance of the neonatologists being with their red flags when looking at the babies. In order to catch those babies that are not detected prenatally. Dr. Balu, you showed us a great experience in your place. How were you able to train all those physicians, and how do you manage competency assessment? And also, how do you manage a centralized data collection? Data collection is super important, and we are miles about. It's very difficult to implement.
Let me try to answer each of this separately. Training, of course, is something which is possible. there's a lot of interest amongst especially the maternal fetal medicine specialists and radiologists, because people are quite scared to miss anomalies these days, especially major anomalies. So there is a desire to learn. So we use multiple platforms, including online platforms, then other conferences of various societies, and then this particular program which we did in Kerala, it was through the government. So we had a meeting with the health minister and convinced her that congenital heart defects are important. And most of the deaths happen in the newborn babies with conditions like transposition, which are correctable. So these were the kind of language we spoke. And we actually could convince the health minister to issue an order through the National Health Mission that this screening is important. So we did that about 8 years back. Now I think a lot of people change. This is a problem with countries like India. The workforce will change. So we may have to do this again and again. The quality check was also possible because what we did was through the same health mission. They followed up, and the people who participated in the training programs were asked to report every case which they actually detected, which was a way of checking their competence. But it is not enough because we can't actually put them through a proper testing and accreditation, which we couldn't do. Databases were very difficult. The databases which I showed were mostly the institutional databases, not the state level. I tried to set up an Kerala state fetal registry, but it is very difficult, especially to set up a governmental level registry because it requires reporting. So we do have a lot of challenges, which I will openly admit. What you saw is perhaps just one ideal way. What if one institution shows the way and we put in the systems, we make a small difference. I will very proudly say that for transposition of great arteries, TGA with intact septum, we did make a difference. After this program, every year at least 20 to 25 transpositions get referred and they undergo the surgery with hardly any mortality. And we have delivered more than 200 transpositions in our center after the inception of this program. So I think it works, but not an ideal system. In India, it is practically almost impossible because it is such a large country. The expertise, the healthcare systems in different parts of the country is completely different. For example, the northern states of India, like Uttar Pradesh, the birth rates are very high. You have extremely good specialists in MFMs who are so good in picking up even the minor defects. But then for large segments of the population, such level expertise is not available. And then to travel such long distances, like very similar to the United States, even though we have only one time zone, but the differences in the distances are enormous. So there is no one size which will fit all parts of India. We tried our best to develop a system in our small state, and perhaps because of the fact that the health indices in our state were really good, awareness was already high, female literacy is very high, we could succeed somewhat.
And your model is great. It would be great if you could, if other places could mimic it.
Yes, we are trying to do that now.
And
Dr.
financial
Vineko,
support is very important. Yes.
Yeah, I'm so sorry. I would love to make a comment here and congratulate Dr. Vidyanathan because I'm originally from Guatemala, and for years we have been trying to establish the pulse oximetry screening, and it's incredibly challenging. I think many countries would love to learn from your experience in Kerala because it's a very large. I noticed that the population is similar to the countries I mentioned in my talk, close to 40 million people. So that's an incredible achievement to do that, right? Without policy like you were able to achieve with the government is very challenging. And I think if this is written, or I hope you give more talks because the world definitely needs to learn from that. And I congratulate you for that work.
Thank you, Emilio. I think it's a very difficult task, as you said, and I have been trying to talk to people, the policymakers in other states in India. And there is a response now because people are keen to learn. The only way to work is to work with people who are really motivated. So you may not find a system we cannot change the system as it is, but there are people in the system who are really motivated, who take it up, and then we make a difference through them. So that way, some small changes will be possible.
It's really great.
Yes.
Dr. Rima, I would like to ask you, do you think that consanguinity might be responsible of a higher prevalence of congenital heart defects in your country? And also, is comfort care an option for neonatal comfort care, an option for babies with severe congenital heart defects like hypoplastic left heart syndrome? Do they do that?
Sure. I just want to congratulate Balu for a fantastic program, and I'm sure we should learn from you wherever. It's a fantastic low-cost program, actually. You didn't actually save money for the government, right? Rather than asking the government to sponsor you, correct?
Yeah, actually, the programs were done without much expense. It
Yeah.
is I think we did away with all the five-star hotel comforts, basic food for people who attended. So we cut away all the frills and just focused on to the training in government hospitals. And I thought it was perhaps some of the good works which we did. But I think it will continue. It should continue, and should continue in many other places.
I'm
Hopefully,
sure we'll try personally to copy you, copy the program as well. What I'm saying, yes, there is a comfort care for hypoplas, of course. We call it TLC, and what they do is that they've decided antenatally that they're not going to go for surgery. So what happens, the baby delivers and stays in the hospital for a few days. And if it's an extreme cases, usually the baby dies within 1 or 2 days. Some of them go home if the doctor is open and the baby is stable, and they die at home. Yes, we have the option. We have the option. What was the second question? Sorry.
Do you think consanguinity could explain the higher prevalence that you had? You talked about 12
Yes, of course, of course. We have a high rate of consanguinity, as I showed you statistically and medically. Of course, this is consanguinity is medicine. It's not me or she. It's a proven fact that you share the genes, and so the recurrence risk is higher. If you have if the mother has a VSD, the baby has a higher rate of having not necessarily a VSD, but congenital heart defect. If the father has a VSD, the baby has a lower risk of developing this. But if the father and the mother are cousins, the baby will have a really higher risk of congenital heart disease if the mother has a VSD, plus having first-degree cousins. So consanguinity medically adds to the risk of congenital heart disease, and that's why in most of the times we do NIPT or for amniocentesis as well. We do the West nowadays with the like I had a case with 8 abortions and baby died day 1 or 2. So looked at it antenatally and there was like tricuspid regurgitation, nothing more, and IUGR. And so we've done the West and it came to be something called Dorsey syndrome, whereas the granulocytes are abnormal and died from at maybe day 3 or day 4. And so for this story is that they are first-degree cousins, they have no living children. So the answer is yes, you have done the mother and done the father and done and we find that the parents are carriers, heterozygous, and the baby is an autosomal recessive disease. But the answer was to do PGD for them if they want to get pregnant again. So yes, consanguinity is very, very important. And by the way, in Islam, marriage from cousins and relatives is not encouraged, but culture overturns religion in this aspect. So people like to keep the to marry from families that they know. But medically speaking, the Islam says, Prophet Muhammad, peace be upon him, said, غربوا نكاحكم. It means that you should not try to marry cousins, as incest is not allowed in all religions because of the genes as well. Consanguinity is not a good thing to have in congenital heart disease.
Thank you. Emilio, you were...
Yeah, thank you, Sophia. I would love to make a comment on that, Rima. And I think we in California, a significant amount of immigration, right, from many parts of the world, all over the world. And I have the benefit of having perspective, being grown and trained medicine in Guatemala, and then came to the States to train. I think consanguinity has a high impact on genetic mutations and genetic malformation in general, and particularly congenital heart disease. In Guatemala, we see it, and many countries in the Latin America is the same, right? Families will meet their partner in the next town, and consanguinity tends to happen, or I believe happens transgenerationally, right? You will meet a person that's 10 years younger, and this happens in very small towns, and the larger malformations tend to happen in public hospitals. Transferring the perspective to California, what happens here a lot is a lot of immigration from particularly the northern part of Mexico. Large immigrant communities migrate to a place where they have a family member or a person they know. So if you go to little pockets in California, they're from the same area. For example, Oaxaca and Guadalajara here in Salinas. And without even knowing, this is not consensual like in Islamic culture, but they don't know, and this might be a second-degree cousin. And we do see, for example, worse and more complex congenital heart disease where in the Valley of California, where there is field workers, than the city. So it's definitely it's sort of like a humoristic joke that the worse and more difficult cases are from the valley, right? And I think consanguinity, we just don't know it and we don't have a way to study it. And I think here is a big ethical thing. But Rima's example and the experience of Middle East is great on pointing out that consanguinity is very heavy, right? Particularly for this type of disorder.
Yes.
Also, this is where culture and religion fight each other. You know, you tell them, you counsel them that please, I know families that are cousins are married to cousins and cousins are married to cousins, especially if they're wealthy. They don't want the money to go out, you know, and they keep telling them, please find a different, no. And also we have to say in outskirts, in the culture that you have to marry your first degree cousin. It's not, and it's not only Islam. In many countries, that especially close societies, that the marriage is already arranged since they're children. So consanguinity is really a health issue that has to be dealt with.
I agree.
Yeah, and a very difficult and ethical thing to study around the world, right? Because some people are consensual and maybe don't care, but some people, like for example, my example of migrants, they probably do not want to have consanguinity, but they don't know it. So studying that is just, I've thought about this for many decades, and it's such a challenging thing, right? Because if you do genetic testing and you find out you're consanguineous, it's just a very difficult thing for a family, right? Sorry, Balu, I interrupted.
We don't go that far. We just do the simple testing, not the complex one.
Yeah, I actually agree with both of you. I have worked with with the doctors in Maldives, which is a very small country, and incredibly high prevalence of CHDs, especially some complex ones like pulmonary atresia, MAPCAs, and it is so tiny. The country is so tiny. Rima might have gone there, and I think it's incredible that such a small country produces such a large number of complex CHDs.
And Balu, can you repeat the country? Sorry, I missed it.
Maldives.
Maltese.
It's where people go for honeymoons. It's a beautiful place.
Yeah, people go for honeymoons there, but probably from different countries. But that particular country, the genetic pool, I think, is a very small one, and then they actually produce one of the largest numbers of complex CHDs which I have come across. But I think this issue is very important, what Rima said, and it should be educated to all prospective families.
Yeah. I want to ask you something. Since we are in the forum of pediatricians, now the pulse oximeter testing, I personally have seen a lot of false positives in it. What do you think? With how you do it, because it depends how you do it and who does it and how you interpret it. There are lots of false positives in my experience. Do you agree, or am I just being in the wrong place, and people who are referring are not doing the test properly.
I agree, because the problem with this is that it leads to a lot of unnecessary referrals for neonatal echo, and sometimes what happens is when you do neonatal echo, you will detect an ASD, a PDA with some amount of pulmonary hypertension, and that leads
Yes.
to more problems, and that baby ends up getting at least one or two more echoes, a lot of parental anxiety, and this happens. I think Emilio did touch upon that first case, the AP window. I really loved it. I think it's another lead.
Thank you, Balu. And that was actually a case that I just recently had. And you feel terrible as a clinician, right? Because you have that AP window, which is such a hard diagnosis. The mom was going to San Francisco because of other anomalies, but still the cost it's just absurd in the United States. It's crazy. You could literally do 4 open heart surgeries for that cost. And to your question, I think Rima was the false positives. I would totally agree. We get so many, and like Balu said, we would get any minor suspicion you hear because the systems are efficient. You say, I sometimes, let's say a muscular VSD, and we confirm it, and we say, I write in my note, non-urgent transthoracic echo in the first 3 months, and this baby is born, and 2 hours later has an echo, and we have, like Balu said, VSD, ASD, PDA, pulmonary hypertension, and this baby has a pediatric cardiologist for the 3 months of life for something that was so little, right? So the false positive rate is very high here in a high resource setting, which is, I think, is worldwide, right?
Yeah, it is a worldwide problem when you have this facility for easy echo, and which has happened in Kerala because the pulse oximetry screening is done almost universally now. And this is the flip side, and the cost factor may not be that high in a low middle income country compared to the high income country like US, but the parental anxiety is amazing. Sometimes I have literally seen parents holding their breath when they speak to you initially, and once you say
Yes.
everything is good, they release their breath. I have seen that. It's
Oh, yes.
unbelievable amount of parental anxiety, and as a parent I would not want to go through that anxiety for sure. So sometimes
Also, I've seen sorry.
Very difficult between false positives and false negatives. It's really a challenge. In low middle income countries, is, as Balu says, not as costly as in the USA, but false negative are dramatic. So you have to choose.
Yeah.
We're
seen a
sort of like doing
coarctation.
that blind spot.
I've seen one coarctation that was missed with a and the pulse oximeter was okay when it was a coarctation. Probably duct was open then, big duct or something. I don't know.
I do think we have a promising future because I think artificial intelligence hopefully will continue to increase that detection rate and become like maybe even foolproof on prenatal ultrasounds. Like if truly AI is that sensitive, we might be able to get better referrals that decrease the number of false positives, etc. Right? So fingers crossed for our artificial intelligence friend.
What do the three of you think about the implementation of the AI? Because I think in my country, there are many places where the echo machines are not good. So the images for screening are not good. How do you think? And I think it might be costly in the initial days, the worldwide massive application of the AI. What do you think about it?
We are actually doing a pilot study with our engineering team, developing an algorithm, and I completely agree. The initial pictures are very critical. It's the quality of the images which are taken, because the images need to be annotated and then screened by the algorithm. So the algorithm basically looks at what you have annotated, and if it is not so good, it can actually, for example, the 4-chamber view, a normal 4-chamber view, if it is somewhat one side is a bit foreshortened, it can actually flag it off as an anomaly. So that is one of the problems. So I think the quality of the initial study is important. So far, as I have reviewed, the most of the studies have been in very selected centers. A population based AI screening protocol has not been done, especially in countries like India or Argentina, where the overall quality of the screening can widely vary from place to place. There could be challenges, but as Emilio said, it is holds a promise. Whatever data people have come up with holds a lot of promise.
Emilio, I think your people are doing, Anita and her team are doing an AI model, right?
Yeah, they already did. This is a paper that actually Balu presented in his talk.
Yes.
Dr. Anita, she trained me, and one of our former fellows, who's now a colleague, Anila Reddy, did this paper that I just texted to everybody. And Rima, her last name is also did a composite of analysis of fetal images. And they have found, Sophia, very interestingly, that even with medium quality images, AI is way better than humans, for sure. And it basically doesn't miss things. It may not catch some, but even if with mid quality images, it's very good. If you provide very high quality images of the sweeps of the 4-chamber 3 vessels and arches, it is higher than 95% detection. So it is very promising. And I think Rima from UCSF did a neural network study on this, which is very, very large and very good. I can't remember the percentages, but they are high. And like Balu said, promising once we get, let's say, imagine ourselves in 10 years, if we get the cost of this AI software very low, and then we can spread it worldwide, I think it will be really helpful for like basic radiologists and people that do like the prenatal ultrasound, right? And you can apply it to the ultrasound and hopefully get referrals more appropriately to the people that they need to be.
Then you'll have a 6-month holiday per year.
Where is that?
And this is what everybody's scared of, that the AI get more intelligent than what we do. But I have done a lot of training in AI, and I think my personal impression is that it's like when you do an Excel sheet statistics or whatever, SPSS, if you rubbish in, rubbish out, if you don't train the model properly, if you don't give the model good things, you're in trouble. And I think we are going to see, and I think when I was in one of the courses, they said there is already legal cases against AI in hospitals.
Yes. I do think, I don't know, I remain very optimistic. I think AI is an outstanding and excellent co-pilot, and you use it as a co-pilot and not as like the know-it-all. It may be not that positive, but I think it will be helpful. Fingers
Yes,
crossed.
yes, helpful, yes, but not the lead, not the lead. This is where we're going to run in trouble. Do you agree, Balu? I see you smiling. I think, do you agree?
I like the phrase co-pilot. So you
Yes.
should be the pilot, and AI should. I agree. I think whether we like it or not, it's anyway going to come. So my
No, it's
attitude
a
is also,
beautiful, it's beautiful, but as a co-pilot, not as pilot. We
yes,
agree to
Yes.
that.
yeah. Thank you.
We'll have to meet again in maybe some months or maybe a few years and talk about this with our each one's personal experience. I thank you all for your presentations. Were really, really excellent. We have to close the webinar because it's almost time. It was very interesting. You all talked about the importance of detecting congenital heart defects prenatally, the gap between evidence and implementation, and the importance of looking for answers and ways of jumping the gap and making prenatal detection feasible for people worldwide. International collaboration, multidisciplinary work, I think, and of course, technology and AI are maybe the clues for improving worldwide prenatal detection. I hope we will meet again and continue discussing this very important topic. I thank you all very, very much. And I will share the screen for people to, for their feedback forum.
Thank you, Sophia, and thank you for the International Pediatric Association.
Yes, thank you, Sophia.
Yeah, it was wonderful. It was almost like sitting together and having a cup of coffee and discussing with friends. It was really nice. Thank you so much.
And thank you for Dr. Haddad and IPA for having this beautiful webinar. And also, it's a bridge between pediatric cardiologists and pediatricians. Sometimes I feel we don't talk a lot to pediatricians. I think we should talk and we should work together more closely.
I totally echo that.
I agree 100%. Well, no, you're all welcome to continue participating in the IPA's meetings and webinars. Thank you very much.
Thank you. Thank you so much.